Dr. Mintz. Gary, are you there? Hey, good morning, Gary.
Hey, Alejandro, how are you?
Excellent. Thank you so much. So I won't take so much of your time. I would like to just welcome you and give you the time to talk and present it. Dr. Mintz is going to talk us today about the images in cardiovascular trials. Thank you.
Sure. So I'm going to go through a lot of information relatively quickly. But the basic concept that I would like to emphasize is that the technique that you select is entirely dependent on the question that you ask. You must define the question first, and once you define the question, then the proper imaging technique is actually, quite frankly, straightforward. So let's first talk about assessing progression and regression. We learned a long time ago that the majority of atherosclerosis is in non-stenotic segments. As a result, the best technique to assess overall plaque burden and progression and regression of atherosclerotic volume is intravascular ultrasound. And the technology or the approach is very simple. You do cross-sectional measurements every, say, 1 millimeter, and you create a volumetric model of the coronary artery, and you determine whether there is progression and regression. Most of this work has come out of the Cleveland Clinic Core Laboratory, and you can see that the change in percent atheroma volume, or overall plaque burden volume, is related to the LDL cholesterol achieved by the study drug. But let's be a little more critical. The first is to realize that the magnitude of change in plaque burden with statin therapy compared to controls is actually very small. You can see that we're talking about tenths of a percent in terms of plaque burden. The second is that plaque burden itself, while an interesting measure, really doesn't predict events. Or should I say the change in plaque burden does not predict events. Clinical events are much more related to the plaque burden at the start of the study than whether the study drug prevents progression or causes frank regression. So it's an interesting quantitative measure, but it really does not correlate well with clinical events. Instead, we're beginning to look at changes in plaque composition because we believe that composition and fibrous cap thickness are much more related to events. This is a study using virtual histology, looking at the amount of necrotic core. It was the EBIS-2 study, and you can see that even though there was no change in overall plaque burden, the study drug, daraplibid, was associated with a reduction in necrotic core, and that was also seen in one of the clinical examples from the study. You can see that the red in the upper panels significantly decreased in the lower panels, as well as an increase in fibrous cap thickness. But probably a better way to measure fibrous cap thickness directly is using OCT. OCT cannot determine plaque burden because there is inadequate penetration to the adventitia through lipid, but it is probably the best technique for assessing fibrous cap thickness. And in this study, which was not a randomized study, patients were divided into statin treatment versus controls, and serial OCT of the fibrous cap thickness was measured, and you can see that statin treatment was associated with an increase in fibrous cap thickness, indicative of stabilization much more than in controls. And finally, a new technology called near-infrared spectroscopy, which has been developed specifically to detect and quantify lipid within atherosclerotic plaque, was studied in a small randomized trial called the YELLOW study, in which patients had IVUS, FFR, and spectroscopy at baseline, and after 6 to 8 weeks of either 40 milligrams of rosuvastatin or standard statin therapy. And although there were differences in baseline shown by the red bars, you can see that with standard statin therapy, the amount of lipid core burden index did not change, while with 40 milligrams of rosuvastatin, a much more aggressive pharmacologic approach, there was an absolute reduction in lipid core plaque, and that was shown here in this clinical study. If you look on the right, the spectroscopy presentation, length is on the x-axis and circumference is on the y-axis, as if you took the artery and sliced it open. And you can see in just about the middle of it, you see lipid that is almost circumferential, interrupted only by the black guide wire, and at the bottom you see a significant reduction in the amount of lipid core plaque. So that's progression regression, but there are other questions that you might answer clinically. For example, if you're doing a study looking at culprit lesions, and we've learned that in ACS patients, culprit lesions may be multiple, or there may not be an obvious culprit lesion, and the best technique to identify the culprit lesion is OCT, because it can look at plaque rupture with the greatest sensitivity, even detect plaque erosion, and of course, it is probably the clinically available technique of choice, looking at thrombus and differentiating red and white thrombus, probably almost as good as angioscopy, which of course is not available outside of Japan. This is another example of a plaque rupture, and you can see that the arrows at the bottom, bottom 4 cross-sectional images show 2 plaque ruptures in this culprit lesion at 180 degrees apart. And conversely, we're beginning to realize that there is this spectrum of lesions that cause infarction that do not have plaque rupture, but that either have plaque erosion or, in this case, probably a severe stenosis alone, leading to reduction in flow and thrombosis. Can we assess vulnerable plaques? Well, to date, the best data comes from the Prospect study, and as you all know, it was 700 patients presenting with ACS, mostly non-STEMI and STEMI, who underwent 3-vessel imaging and then follow-up of about 3 years. The imaging predictors of events were a plaque burden more than 70%, a thin cap fibroathyroma by virtual histology, and a lumen area less than 4 square millimeters. And if you had the triad of these 3 findings, the event rate was 10-fold compared to the absence of this triad. This was substantiated by a study called VIVA that I'll show you in a minute, but just as importantly, non-fibroathyromas, either pathologic intimal thickening, fibrotic plaque, or fibrocalcific plaque, were quiescent over a 3-year period of time. And this was, as I said, supported by the VIVA study. So if you're doing a study today looking at vulnerable plaques, you have to look at plaque composition. And the best technique that we have currently available is probably virtual histology. It may not be the best technique in the future, but is a technique where we have the most data today because of both the Prospect study and the VIVA study. By OCT, we can look at the fibrous cap thickness, as I already mentioned, as well as macrophages within the fibrous cap. And by spectroscopy, we can look at the amount of lipid in the vessel wall, and that will be the premise for Prospect 2, in which we will identify patients with a lot of lipid core plaque and not only follow them as we did in Prospect 1, but take a small group of patients and randomize them to BVS implantation versus control to see whether it makes sense to treat vulnerable plaques as we have detected using intravascular imaging. There have been a lot of papers looking at distal embolization and preventing distal embolization during stent implantation. And as you know, the data is all over the place. Single studies suggest that it makes sense to do aspiration. Multi-center studies have failed. And one of the reasons may be that they're just looking at all comers. They're not identifying or attempting to identify lesions that have a high potential for distal embolization. And there are a number of techniques to do this. Grayscale IVUS, looking at attenuated plaque. This is plaque that is not echo-reflective, but the ultrasound does not penetrate to the adventitia, and this is consistent with a lot of necrotic core, both using virtual histology, but also using histopathology. There are a plethora of papers looking at virtual histology itself, indicating that the amount of necrotic core or the presence of a VH thin cap fibroathyroma predict distal embolization. There are OCT parameters an OCT thin-cap fibroatheroma also predicts distal embolization, and by spectroscopy, the amount of lipid core plaque can predict the distal embolization. And this is a clinical example of a patient with a lot of lipid core plaque in an ugly lesion in the mid-right coronary artery with predilation, the vessel closed, the patient went to heart block and could not be resuscitated. So in this case, if you want to do a study trying to minimize distal embolization or prove whether or not distal protection or aspiration makes sense, you probably should not just do an all-comer study, but instead select patients who are at a high risk of distal embolization, or on the other hand, exclude patients that you know will not have distal embolization, and therefore create a much more efficient study. To assess acute DES results, we have a ton of data, mostly from IVUS. These are all the studies looking at predictors of early DES thrombosis or restenosis, which are two, underexpansion and edge problems. This emphasis on malapposition has to stop because acute malapposition does not lead to adverse clinical events. We have a lot of data in terms of whether IVUS guidance reduces events, and if you're going to do a study looking at determining what is the best way to reduce events, you have to have some background. And a meta-analysis published in Your Intervention indicated that IVUS guidance reduced death, stent thrombosis, and MACE. An unpublished meta-analysis by S.J. Park supported it, and there'll be a paper that will come out in JACC Intervention, a meta-analysis of all up-to-date studies indicating that IVUS guidance reduces death, MI, stent thrombosis, repeat revascularization, and MACE. It is possible that OCT can do as good a job. This is a study from Prati in Rome, where they compared angiographic versus OCT guidance, showing findings similar to what I just mentioned with IVUS. But again, looking at what study is the best study to pick when doing an IVUS guided or IVUS endpoint study, there's only one head-to-head comparison from Japan and a small number of patients, suggesting that at least today, with the data that we have currently available and the knowledge that we have as to how to use IVUS and OCT, IVUS is the primary technique of deciding, of using in a stent guided implantation trial. A lot of work now being done on bifurcation stenting, either using crossover stenting or using true dedicated bifurcation stents. Angiographically, these are almost impossible to assess. This is a pre-intervention left main after stent crossover. Everybody I show this case to would say they would definitely treat the ostium of the circumflex, yet the ostium of the circumflex is unchanged from baseline. So if you're going to look at a study where the endpoint is what happens to the ostium of the circumflex, either acutely or at follow-up, you have to have a metric to assess it. And angiography is just plain misleading. Probably the technique of choice, the one that I would use, is FFR, and do FFR of the side branch to determine whether it is compromised acutely or whether it was restenotic at follow-up. The angiogram is simply unreliable. These are two studies, both from Korea. The acute compromise of the ostium of the circumflex is about the same, 18 and 27%, but yet the angiographic diameter stenosis profile is totally different, which only to me emphasizes how unreliable the angiogram is in assessing the ostium of the circumflex. Finally, stent failure. Most stent versus stent studies included an IVUS sub-study looking at intimal hyperplasia. I think we have gotten beyond that, particularly with some of the newer observations about late causes of stent failure. So these are all the imaging related or imaging identifiable causes of stent failure: procedural complications, intimal hyperplasia, neoatherosclerosis, and so on. And depending on whether we're talking about a bare metal stent or a drug-eluting stent or looking at stent thrombosis or restenosis and the timing, you can see that the causes are different. I mean, stent failure is not a unified disease. It is a syndrome with many, many causes. And I'll just mention one of them, this fascinating entity called neoatherosclerosis, which we probably ignored in the past. I remember cases that presented with bare metal stent restenosis 4, 5, 6, 7, 8 years after implantation that we treated with brachytherapy 10 years ago, and that probably was just unrecognized neoatherosclerosis. The technique of choice in assessing neoatherosclerosis, has been shown by all the studies that I've listed here, is OCT. It occurs earlier in DES than in bare metal stents, with greater frequency, probably in all kinds of DES compared to bare metal stents. It can present either as late in-stent restenosis or very late stent thrombosis, and is probably responsible for the majority of very late DES thromboses, and these patients tend to present much more unstable than those patients who present with stent failure because of garden variety intimal hyperplasia. These are just some clinical examples. Let's go across from left to right. First at the top, you see these little holes in the neointima. You also see how nicely OCT can measure intimal hyperplasia thickness. The second example is an example of a thin cap fibroatheroma within the neointima. Third example is frank calcification. Fourth example is red thrombus. At the bottom, you have two examples of neointimal rupture, a mixed thrombus and a white thrombus. And way here on the right, you see this dark, jagged line within the neointima, which is one of the best examples of neovascularization that I've ever seen. So quickly to conclude, the technique that you choose as part of an imaging study depends on the question that you are asking and the question that needs to be answered. There is no one technique that fits all clinical trial situations. Start with the question, start with a hypothesis, and once you do that, then the clinical technique becomes obvious. Thank you for your attention.
Thank you, Gary. Excellent presentation. Let me ask the audience if there is any question. ¿Alguna pregunta de la audiencia? So we early dismiss you. Thank you so much. Any question from the people that is at remote? No. Gary, thank you so much. This was an excellent presentation.
We'll see you all in 10 days.
Thank you.